Thank you everyone for coming here, to participate in this session today. As you all know that universal health coverage has become a very important issue at the global and national level also. But today, your presence has shown that it is a very important issue at the state level also. So thank you very much for taking time out to attend this session. We have structured the session in a way that we start out with an introductory session. We introduce ourselves and get to know each other better. And because the program requires that we have a pre and post assessment of the understanding about universal health coverage at the conceptual level and as well as at the state level. So we'll have a short write-up on two questions. What is your understanding about universal health coverage at the conceptual level? And what do you think is happening in Meghalaya in terms of universal health coverage? So just briefly, two questions. And then I'll make a brief presentation about the way I see universal health coverage. And the idea is that we don't just discuss the concept of universal health coverage, but we also see how to analyze the situation in Meghalaya based on the conceptual understanding that we develop here, and also what are the challenges of universal health coverage in Meghalaya and what can be done going forward. So going forward in terms of solutions to those challenges and how we can develop a local leadership and collaborative, most importantly, collaborative of stakeholders. Because as you all know, universal health coverage requires different stakeholders to come together. Policymakers, communities, and industry and media and others. So how can we develop a state-level collaborative of stakeholders in Meghalaya going forward? So this is how the session is going to be structured over the next 2 days. So maybe until the electricity comes and we start. So we can start with the introduction. So should we start with you? Or maybe I can start with myself. So my name is Ali Mehdi. I did my PhD from Humboldt University, Berlin on child health. And, after that I came to India and I set up the health policy initiative at the Indian Council for Research on International Economic Relations, ICRIER. So ICRIER is a policy research institution which was set up by the former Prime Minister of India, Manmohan Singh, and Montek Singh Ahluwalia and many others. So there I led the health policy initiative for several years. Over the past 3 months I have joined Sambodhi and now so I'm conducting this program as part of Sambodhi. So I'm a Deputy Vice President of Public Health at Sambodhi. So we can now start with our presentation and then we'll have a short tea break after the presentation. And then we'll do a group activity about, how, we can use this conceptual understanding of universal health coverage to analyze the status and challenges of universal health coverage in Meghalaya. And then we'll have short presentations after lunch, from your side. So, is this clear? We have 3 objectives for this entire, program. The first is that we develop a thorough understanding of the key concepts of universal health coverage, especially in the context of sustainable development goals. That's one. And then how do we use this understanding of universal health coverage to analyze the present status and challenges of universal health coverage in Meghalaya and develop solutions. And the third is that how do we we'll discuss how we develop a local leadership and stakeholder collaborative to accelerate universal health coverage in Meghalaya. So let me start out with the first one. Key objectives. So as you all know that the WHO has given this definition of universal health coverage that all people have access to the full range of quality health services they need when and where they need them without financial hardship. So it covers the full continuum of essential health services from health promotion to disease prevention to treatment, rehabilitation and palliative care across the life course. So now this is the UHC cube so that the WHO has developed. It has 3 dimensions. So one is the population side, who is covered and who is not covered. The second is the services, the health services dimension. What sort of services are covered? The third is the direct cost. How much are people paying out of pocket? How much is the government paying? So the idea is that this blue box needs to expand and cover more and more people, more and more services, and reduce as much direct cost as possible. So this is how the WHO conceives of universal health coverage. We don't have to agree with this. We can have our own understanding, and we can have our own views. But this is how the WHO conceives it. Any question or any doubt about this? We can go step by step. Then we can. I think. Okay. So there is a short YouTube video, just 2 minutes, which shows about this understanding of UHC by the WHO and some short case studies. So it's just a 2-minute video. Let me see if it works. Now, I have developed, I'm actually in the process of developing a concept of the universal health coverage, in which I talk about, a comprehensive approach to universal health coverage. Like, as you know, as part of Ayushman Bharat, there is a concept of comprehensive primary health coverage, CPHC. So I call this notion UHC 360, because 360-degree normally means it's comprehensive and it incorporates the views of various stakeholders and groups. Now, when I say, so how do we define the 3 key words in universal health coverage? So by universal, we mean that everyone has health coverage across the life course as per their needs. So everyone is covered, and according to their requirements, they get health care across their life from birth till death. Secondly, health I define as various types of health, both physical and mental, because like you are from this Mental Health Institute, and mental health has become a very serious issue. So we cannot, so normally this does not come out very clearly in the WHO definition, mental health side of it. I mean, they say all types of care, but this needs to be very explicitly laid out, because mental health is becoming a very serious issue. So various types of health and continuum of health services are covered, from promotive to palliative. Because normally when we talk about universal health coverage, if you ask people in general, they will say health insurance. Health insurance is a very common thing that people think about universal health coverage, that you provide health insurance. But health insurance largely covers hospitalization costs. I think in Meghalaya you have also covered OPD costs also. But normally the perception about, like, people also buy a private health insurance and it only covers you when you are hospitalized. So that sort of understanding has to be tackled, that universal health coverage does not mean hospitalization or even just curative care. It also covers, promotive health promotion, disease prevention, and rehabilitative, palliative, all sorts of healthcare are covered, ideally covered. And various types of health are also covered. So not just physical health, but also mental health. I mean, you could also include social health here also, and some people talk about spiritual health also. Now, what is the coverage part? Coverage is that population, and like population is from the universal side, and health coverage should be such that everybody can attain their highest attainable standard of health without financial hardship. Now, universal health coverage is not just providing services without caring about the outcomes. Because, a lot of times, like I know we have been involved with the World Bank project in Gujarat, where they are trying to strengthen quality of care in primary health systems. Because the argument is, you can provide services to people, you can provide these services, but if these services are not of good quality, they will not lead to the desired health outcomes. Because, you're not providing care just for the sake of it. There has to be a certain outcome to it. And the idea of highest attainable standard of health is written in WHO's constitution. And it's also written in various government health policies, like in the National Health Policy 2017, I think also in the Meghalaya State Health Policy 2021, right? So, I mean, there is a clear-cut argument about the outcomes also. So, our care, the health services that we provide, have to be very outcome oriented. We have to see what sort of impact are they having on the society as a whole, and on specific health outcomes. So that sort of orientation needs to be brought into universal health coverage, the outcome orientation. And the way World Bank defines quality of care is very outcome oriented. It's not just about giving good quality medicines and everything, but it's also about how this process of care is leading to health outcome. So this is very important, that the population and health coverage should be such that it leads to the desired health outcomes without financial hardship. These are the two key aspects, that people get the health services and without getting impoverished, because healthcare is one of the major areas which leads people into impoverishment. And the World Bank's main focus is on shared prosperity and reducing poverty, and also the SDGs. If you look at the document of Sustainable Development Goals, they say the greatest threat to development is poverty. Our greatest enemy is poverty. So how do we deal with poverty? And I was looking at the presentation by Dr. Sampath Kumar also, and here he says a lot of women hesitate in Meghalaya to go to seek healthcare because they feel that they cannot afford that. So, the financial consideration is very strong when you talk about healthcare. And if you seek healthcare, it can also lead you to poverty. So, this linkage between healthcare and poverty and, the financial side is very critical. The fourth side is that it's a collaborative that, that needs to be developed between experts and stakeholders to identify the challenges and develop and promote solutions to accelerate UHC. Because you see, we are sitting here in this room. There are people out there, they will have different views about these things, the way they see universal health coverage, what their needs are. So there has to be a constant interaction and collaborative between communities, other stakeholders, policymakers, industry, international organizations, experts. They all have to come together, because UHC is a very complex thing. It's not a simple thing, it's not like a leaflet that you give out to people. UHC is not like a package, the way packages have been given to you. You cannot just distribute UHC like this. It's a complex thing. Everybody has to come together. So how do we develop that sort of collaborative? And there is a very important notion about, community health services, community, health workers, CHWs. And I think in Meghalaya also there is a strong focus on communities. So that aspect is also very critical. So I'm still working on this notion, but this is what I call UHC 360. Now, this is the UHC Sustainable Development Goal. So goal, as you all know, the Sustainable Development Goal 3 is about ensuring healthy lives and promoting well-being for all at all ages. Now, this is the goal we need to be very clear about, because normally when we talk about UHC, we look at the two indicators, but we forget that behind these two indicators there is a goal. We have to reach this goal. So again, you know what I was referring to earlier, there has to be a strong health outcome orientation, and that comes from this goal of, you know, ensuring healthy lives and promoting well-being for all at all ages. Now the specific UHC target is 3.8. It says that, you know, people should have universal health coverage, financial risk protection, access to quality essential healthcare services, and this and that. Now, indicator 38.8.1 specifically is about the coverage of essential health services. Now, the WHO has developed with the World Bank index of this essential health services coverage, which they for which they use the 14 tracer indicators, which I'll show you in the next slide. So these are the 14 indicators that the WHO and World Bank use to develop their universal health coverage service coverage index in their UHC report, which they bring out annually. So there are 4 indicators in reproductive, maternal, newborn and child health, 4 in infectious disease, 3 about non-communicable disease, and 3 about service capacity in excess. Now they use this sort of formula to develop an index, and at the national level they give you the report. Now they themselves say, if you look at the metadata, the UN Statistics Division that it has put out, it says that these 14 indicators are not comprehensive. They have selected these 14 indicators because you readily get data on these 14 indicators. So UHC is not just about these 14 indicators. So let me clarify. If you achieve full coverage on these 14 indicators, it does not mean that you have achieved UHC. This is just a sample. This is the core essential health services, you know. So it's not an exhaustive list. So we need to keep this in mind. And the reason to select them was very practical because data was already available on these 14 indicators. Now, the UN agencies, the World Bank, they develop an index based at the national level using these indicators. But countries also need to develop their, you know, own computations based on these indicators at the national and state level. Because right now, if you ask me, where does Meghalaya stand? I don't know. Because there is no, index for Meghalaya compared to other states. So this calculation right now is only being done at the national level. So we know what the coverage, what the index is for India and other states or the other countries, but we don't know for the states. More importantly, we don't know for different communities because health, universal health coverage is about health equity, and we don't know how different communities are doing on this index. So from the National Family Health Survey, we get a lot of data by background characteristics, by wealth quintile, by education, by caste, religion, by, type of residence. And so we do have data, some of the data from the NFHS and other sources. So we can use that to calculate this index by background characteristics. But this is something that needs to be done within the country. And I'm at least I'm not familiar if somebody has done this. If you know, let me know. So anybody knows that if there is a Universal Health Service Coverage Index at the state level? Any idea? Do we know what the rating of Meghalaya is vis-a-vis other states on universal health? Is there any number that we get? No, we don't have, right? So this is something which is very critical, that because how do we know if we are making progress? How do we monitor this progress? Now the last thing here is that they say that indicators 3.8.1 and 3.8.2, which is about financial protection, should always be monitored together. Because it's not just about having these services, but also seeing its impact on families and communities. Now 3.8.8.2 is about the proportion of population with large expenditures, household expenditures on health, greater than 10% and 25% of total household expenditure or income. Now this is where the critical part is. I have seen, I did my doctoral field research in Saharanpur district in Uttar Pradesh, and I see that even poor people want to have good quality health services. They go to private sector to get good health services. but as a result of that, they get impoverished. Now, they are getting good quality services, but at the expense of getting impoverished. Now, this is where the interlinkages of universal health coverage with the broader SDG framework comes into play. Because the broader SDG framework is about, eliminating poverty. And healthcare is something that is constantly pushing people into poverty because there is a vibrant private sector where quality services are available compared to the government health sector. But if you access that and if you are not so rich, you will end up being in poverty. I'll give you an example. During the COVID-19 second wave of COVID-19, I'll not name the hospital, but in Delhi, there were good quality hospitals which were charging a minimum of 20 lakh rupees per person for COVID-19 treatment. And some hospitals have even charged 3-4 crore rupees per patient. Now, imagine who will pay, and they refuse to give the dead bodies also, So in some cases, there was a person who died in a premier private hospital. The total bill was 3 crore rupees. And they said they will not give the dead body if you don't pay this bill first. So, you can get good quality coverage, but then what happens? You become poor. Your family becomes poor because they will pay the bill and then, so these two indicators have to be looked at together. So, how do you get good quality health services without becoming poor? But let me also give you an example here from Sri Lanka. So, before this crisis happened in Sri Lanka. So, before this, Sri Lanka was given as one of the great examples of universal health coverage. And they had done, a great job. Everybody had access. There was a great deal of accountability of government health services. Community participation was very strong. But at the same time, they also allowed private hospitals to flourish. So, a lot of private hospitals were also there. So, government health services were good. There was strong accountability by the communities. At the same time, they allowed private hospitals to be there because they said, if you want to go to the private sector and you have money, I'm not stopping you. You want to go to Apollo Hospital, Max Hospital, it's your choice. I also don't want to reduce the choice for you. You have the choice, but at the same time, I as a government, I'm going to provide services to everybody. Anybody can come and they will be of good quality. And if you see, before this crisis, Sri Lanka has always had excellent, health indicators compared to, better than all countries in South Asia and at a fraction of the cost. But at the same time, if you look at the data on out-of-pocket expenditure on health, it was always very high in Sri Lanka. So I think we also need to keep in mind the element of choice. By universal health coverage, by government health services, it does not mean we stop or finish off the private health services. We can let them be there, but we need to provide good quality government health services because some people will be super rich. They would want to go to these private facilities. This will also reduce crowding in the public sector. So we can let them go there. Any questions or thing that you want to discuss at this stage? I don't want to rush, things, but anything that you, or any opinion that you have, on this, any comments, suggestions? Anything anybody wants to say? Legislative. Okay, sure. So now this is a quotation from the political declaration of the UN high-level meeting on universal health coverage that happened in 2019. And this is again happening in September 2023, a political high-level meeting on universal health. So universal health coverage has become a very important thing at the international level, thanks to the UN system and also the G20 presidencies of Germany and Japan. So Germany and Japan have also pushed it a lot at the global level. And because Germany has, started universal health coverage, Bismarck, the German ruler, he had initiated universal health coverage in the 19th century. And then Japan is another country that had quickly expanded universal health coverage. So they have done a lot at the international level to promote universal health coverage. And so there was a special meeting on universal health coverage of all heads of state in 2019, which is again going to happen this year in September. Now, in that statement, they say that universal health coverage is fundamental for achieving sustainable development goals, not only just related to health, but also to eradicate poverty in all its forms and dimensions. And ensure quality education, gender equality, women's empowerment. Because see, there is a lot of synchronization between these things. If women are educated and empowered, it also leads to better health outcomes. That is the data that we get from demographic and health surveys also. So wherever women education is strong, empowered, women are more empowered. Like in Meghalaya, I see that it's a very good example. So their health outcomes also tend to be better. Similarly, it also reduces poverty, as we said, that it reduces out-of-pocket expenditure, and also it has a two-way relationship with poverty. If people are healthy, the workforce will be healthy. They will earn more money. The companies or organizations that they are working for will also do better. It will also lead to better economic growth at the national level. So, healthy population is equal to healthy, households, healthy, economic profile, healthy companies, and healthy economy at the national level also. And also at the same time, government-supported healthcare reduces poverty. So, it's a two-way relationship that works. And also, they say that it's also linked. So that is the sort of, interrelationships that they talk about in this political declaration, how universal health coverage is very fundamental to the realization of other sustainable development goals also, not just the health ones, but also the other ones. Now, the WHO further argues that primary universal health coverage has to be anchored in primary health care. Now, primary health care is not the primary health centers only, it's also about care being provided in the communities. So, primary health care is not just the building, it's not just the institution, but also care being provided by community health workers, for example. So, community health is also a very critical part of primary health. So WHO argues that primary health care can deliver almost 90% of the universal health coverage interventions and also achieve 75% of the projected health gains from SDGs. So there is a very strong focus by WHO, UNICEF and others on strengthening primary health care as part of universal health coverage. Because what we have seen is that specialization has increased. Now, let's say you have a heart problem. You go to a hospital, tertiary hospital, a cardiologist will see you. Then you say, I also have this problem, he'll send you to other person also. But with the rise of chronic non-communicable diseases, there is a lot of comorbidity. You have multiple things at the same time. You don't have one problem, you are one person. So you may also have mental health issues, you may also have diabetes, you may also have multiple other things. So this coordination of care is best suited at the primary healthcare level, because this is also where communities live, and the interaction with communities, the community accountability will be highest, which is why the National Health Mission is a very important role that it has played in improving India's health outcomes. So this is very critical, that primary health care has to be strengthened, because we increasingly see that tertiary care has taken over the health sector in multiple countries. So I was in Canada also, and there used to be a system of family doctors, and they used to know the entire families, the family history and everything. But they say that with increasing specialization, that family medicine system has also been reduced there in Canada, which is why they are having challenges. The cost of healthcare is increasing. Now that's another thing that we'll discuss later on. Now, this is another thing. So, this is my argument that universal health coverage, at the core of it, there should be three things. One is health promotion, the other is disease prevention, the third is the quality of care. Now, health promotion and disease prevention, they help you not only to promote health, well-being and quality of life, it's a more proactive thing. You empower individuals in communities to improve their health. You're not just waiting for people to fall sick. So curative care is, you are sitting there. So let's say this is a hospital, I am a doctor and I am sitting here for a patient to arrive. Now, the patient is already sick. The health promotion and disease prevention is, I am not waiting for people to turn up to my facility as sick patients. I am going out and trying to prevent illness. Now, this is a very cost-effective strategy for low and middle income context also, because they don't have the money, and even rich countries are struggling with the rising cost of healthcare. So even in the US and Canada and other countries, in Canada they say the metric for our success is that how do we achieve the best health outcomes through minimum expenditures. So that's, this rising cost of curative care is very critical. So health promotion and disease prevention not only help us in proactively promoting health, well-being and quality of life, because you see, once you fall sick, as you all know that the non-communicable diseases are the biggest killers now everywhere, including Meghalaya and everything. If you have 4th stage of cancer, it is not reversible. Early detection can still be reversible. If you have early diabetes and you are diagnosed with diabetes, early cancer can still be tackled. But the damage that they do to your system is not reversible. So we should not wait for these things to strike. There has to be a more proactive approach to, sorting out these problems at a very early level. Now, these two things also help delay the onset and reduce the burden of risk factors, morbidity and mortality, especially premature. Now, India has been the world's largest contributor to premature deaths. By premature, we mean under 70 years. Now, the reason for that is because the onset of risk factors, which is, for, let's say, chronic disease, is, blood pressure, blood sugar, lack of physical activity, tobacco consumption, alcohol consumption. There are multiple things. Now, these things start very early. You see a lot of people dying due to heart attacks in 20 and 30 years of age also. Now, that is a very early onset of, risk factors. So, how do we delay the onset of risk factors? Through health promotion and disease prevention, and also reduce the burden of these things, because right now our hospitals are overburdened because the burden of these things are extremely high. There are so many patients, so we have to stop people from becoming patients. How do we stop this? Then it also reduces the, as I said, excessive burden on curative health systems and staff, because if you see, I was also going through the presentation by Mr. Sampath Kumar, and he says, what are the challenges for universal health coverage? Lack of adequate staff. Now, this staff is largely the curative staff. If you have strong health promotion and disease prevention practices in place, the burden on these systems will also reduce. So, we have to think about reducing the burden on the economy, the financing of healthcare, and also on the health systems which are catering to curative care. Then again, the reducing the spiraling cost of curative care and increasing the financial viability and acceptability. So, you see, Japan, when it had the G20 presidency, it had a joint meeting of health and finance ministers. If I ask you, in Meghalaya, where do I go to sell the idea of universal health coverage? How do I promote, which ministry should I go to promote universal health coverage in Meghalaya? Anyone? Which is the first place I should go? Which ministry? So let's say if I ask for your suggestion, let's say I'm here, I want to promote universal health coverage in Meghalaya. So let me ask you, which is the first department or ministry where I should go to make an argument for it? Family welfare, health and family welfare. Any other? The whole thing about universal health coverage. Everything related to universal health coverage, which is the first place I should go to. See where the money is coming from. The money is coming from the finance ministry. If there is no money, you cannot do anything. So that is the first place. Now, how do you convince finance ministers to fund universal health coverage? You have to give them a viable idea. If you say, spend 5,000 crore rupees, they will say, go away. You're not doing anything. So I remember we had called the WHO director, India country director for a function, and he said, I met the finance minister of India and I said, chronic disease burden is rising, you should do something. People are dying due to chronic disease. So he said, people have to die. How does it matter if they are dying due to chronic disease or whatever disease? People have to die anyways. So that's not the argument. So you have to give a very convincing argument to the finance ministries, because that is where the money is going to come from. Even the Department of Health and Family Welfare has to give a demand for grants, to the Finance Ministry, that on the basis of that the budget is developed. So that's the first place. And how do you develop a viable, vision of your UHC for the Finance Ministry? Then you have to tell them that we will take measures that will reduce the burden of disease as well as reduce the burden on financing. And these three things are very critical from my perspective. I mean, you can disagree with me, but this is what I feel that will reduce the burden on health systems as well as health financing. Then the last is that this is also very important for improving the health of the workforce and the economy at large. Because if your workforce is healthy, they are earning well. There is, I just saw that there is a center for early childhood development. So if you look at the population dynamics, there is a dependent population, there is a working age population. Dependent population is defined as 0 to 14 years and then 65 plus. So 15 to 64 is the working age population. Now, even in our homes, you see, children don't earn. It's, people who are, these people in the age group of 15 to 64 who are earning. If this population itself is sick or dying early, how will they support the dependents? Dependents is your, people 65 plus and the children also in the family. So the health of this population segment is very critical because if they are healthy, the economy will be healthy, their companies will also be healthy. So these steps will help us, to ensure all these things. And finally, without quality of care, you can have 100% UHC, but it will not lead to the desired outcome. So quality of care is also very critical. Now, this is what I call the leaky bucket of UHC, that this is health financing. You keep putting the money, but if there is no disease prevention, health promotion and quality of care, the bucket will never get filled because you are constantly putting the money into UHC. You are not going to reach the desired objective of better health. So this is what we need to prevent through these three activities. So here, to prevent this from happening, we don't just need interventions at the individual level, but also at the community and population level. So how do we, design population health programs for UHC? Now, again, this is a very serious misunderstanding about UHC, that it's all about the individual. Ayushman Bharat, you give the card to the individual. Primary healthcare interventions, a lot of them are targeted at individuals. Now, what about the community level interventions, population health interventions, also the social determinants of health? So these are some activities which can be undertaken at the population level. Addressing the social determinants of health, which we talked about earlier. Improving women's education, community engagement, accountability, all of that. Water and sanitation. And I see that Meghalaya is already a very clean state. I see so much cleanliness. I was so inspired yesterday when we were coming from Assam, because I come from Uttar Pradesh, and Uttar Pradesh, the things are so dirty. And I'm really impressed that, so there's already a lot of things which are happening here as far as, public health is concerned. Road safety, maternal and child health. So these are all interventions that we can do at the population level to prevent the leaky buckets of UHC. Yeah, so I'm done. This is all I had to say. Now, any questions, comments, suggestions, and please feel free. So after this session, we'll have a quick tea break. Then we'll come back and focus on this part of the whole thing. Any comments, suggestions, critical inputs? Anyone? Or otherwise, I'll start one by one to ask for your inputs. Should we start from you, ma'am? Any comments you would like to make about what we have discussed so far?
In the sense that we have rolled out the Ayushman Bharat initiative, and we have interventions at the primary health level, whereby we have dedicated medical team, like we call her the MHP or she. So I think she is the dedicated person to take care of the expanded services. Right now, we are not just addressing the RMCH services, but we have expanded to other non-communicable and even infectious disease. So that is one thing that is happening. But the thing that you have just rightly highlighted regarding the coverage and the what we call this, the stakeholders and the community partnership. I think the government of Meghalaya is already working a lot on this with the institutionalization of the village health councils, whereby we are planning to empower the community for demand generation activities as well as promoting ownership and access to healthcare services. Of course, the World Bank project through the government of Meghalaya is also there to support the infrastructure and ensure that the out-of-pocket expense through quality healthcare is being also improved through the health insurance scheme. So I think we are already in this journey, but maybe we just need to identify our goals, like the index, like what you have said, like based on the need of the state of Meghalaya, as to how can we work on this towards the goal. Right now, it's a very generic SDG goal, like for everyone, but maybe for Meghalaya, we have to dissect a little bit more and see like what do we need and how can we improve towards contributing SDG.
Very true, very true. No, I completely agree, because I think right now we have a very generic approach to US. We say everybody. Now everybody has a different requirement also. So, there is also this concept of State Capability Enhancement Project, right? SCEP. Now, if you look at Amartya Sen's capability approach, Amartya Sen says that there is extreme level of human diversity in terms of internal characteristics and external, circumstances of people. So people differ a lot, and which is why he also made this capability argument that capabilities need to be strengthened, because, people are different. So healthcare needs also very different. So the service coverage index of the WHO, which has 14 indicators, it's not sufficient for everybody. What about an elderly person? He has no reproductive and child health thing. He is already elderly. He needs palliative care, for example, or rehabilitative care. So everybody's health needs are also very different. So we need to have different packages for different segments of the population also. So that's I completely agree with you. Anyone else? And you completely rightly pointed out that this is not a new thing. Even in India, so universal health coverage journey started in India before independence also. So we had this, employees state insurance scheme, ESIS. So this discussion started before independence. And in 1948, the ESIC was formed. So that's actually a very comprehensive coverage, not just health, but also other things also involved in it. So this is, universal health coverage is not a new thing, but we need to have a clear vision for it. And how do we monitor our progress going forward? That's anyone else want to say something? Because we need to now, in the sessions going forward, we need to use this understanding to analyze the challenges and status of UHC in Meghalaya based on what we've discussed, and then how do we develop solutions in Meghalaya, and how do we develop a collaborative in Meghalaya. So if there are any questions, we can discuss now, because my part is now over. Now it will be your part to have group activity and discuss the challenges and status of universal health coverage in Meghalaya. So the next session after tea break will be about group activity. How do we do that? So if there are any questions, please feel to ask. We can discuss right now. If not, we can.
So according to your experience with various countries that you've gone ahead with the project, what actually is the main lacking, the thing that which is lacking behind with India?
In India,
according to projects,
in terms of health. Yeah, I feel that this understanding of health is very important, because I was very impressed when in Canada they said that their primary focus is on health outcomes, not on health expenditure. Because if you look at the US spends the most on health, but its health outcomes are worse than Cuba. Cuba spends very less, but does much better than US. which spends a lot. So there is no linkage between your expenditure on health and the health outcomes. There are multiple other things. And I think that is where, a lot of conceptualization of UHC is very important. Because if you feel, what do I do as a, being in the government, what can I do best? If I want to please the people, let me give them health cards, and this and that, and curative care, and give them health services. But that's not going to make the population healthy. And that's why a lot of people are caught into poverty and, and they are not healthy and they cannot perform better, and it creates a loss at the household level, at the company level, at the economy level also. These things are interlinked. This interlinkage again is a very crucial issue. COVID-19 has shown for the first time to the world, if there is a health risk, it will collapse everything. There will be a lockdown, everything will shut down. Your economy will collapse, everything will collapse. So a small virus, can bring to halt the entire world, close down the entire world. That's the importance of health, which was earlier not appreciated. Now people are talking about the interlinkages also. And that's the best part about SDGs. So SDG is about pursuing an integrated approach. Now that's again a problem area. That like in Canada, they say every policy is a health policy. Because let's say you have a policy on alcohol consumption. So like Delhi is a classic example. Delhi gets the most amount of revenue from alcohol. At the same time, they also have a department of prohibition. They want to stop also. So their most amount of money is coming from tobacco and alcohol, but at the same time, they also want to stop it. Because that there is a negative impact, but your money is also coming from there. So how do you achieve that sort of balance? So I think these interlinkages and the focus areas, like I argue that, health promotion and disease prevention, this is a cost effective. So that sort of focus, I think, this is my understanding. This is just how I see things. But you can disagree with that. Any other comment, suggestion?
Well, okay, if I may.
Yeah, please.
Do excuse my brevity. I just speaking my mind in addition to my behavior. I think this entire capacity, or rather the regulation of the universal health coverage, if we could, dive into the Meghalaya context, wherein there are certain interventions that has already been initiated, like she has mentioned, under the Ayushman Bharat and wellness component of the assist primary healthcare, and also there's the MHIS component, the health insurance scheme, which is already moving towards a direction which is trying to achieve the maximum coverage on our beneficiaries, and also other things such as there are certain activities and investments which have been made in the healthcare sector, trying to improve the healthcare indicators. For example, the involvement of technology in reducing the maternal and child deaths. Where we try to track the mothers and all through the mother app and all that. We have certain activities like the rescue mission, where we have weekly reviews with the districts and the health facilities and finding out the gaps and so on and so forth. There are various kinds of interventions, like she mentioned, the village health council, which is another, I would say, innovative, kind of a pilot which the state is doing, which we have a high hope on achieving getting the targets which we plan. And if we can have that, that discussion on that aspect, it would be much more practical and more conducive in the arriving at certain kinds of challenges and mitigating those measures.
Exactly.
How do we go about it, overall structure of the because universal health coverage, like you mentioned, has been there for a long time.
Exactly.
But how do we see it from the Meghalaya's perspective?
Exactly.
I understand we have different kind of well-renowned models, but why don't we look at it as Meghalaya models of some sort?
Exactly.
Trying to bring, tweak the existing system and bringing the maximum efficiency out.
Very true. I completely agree with you. Because, which is why, we thought that we'll only have one session about the conceptual part, the rest will all be about Meghalaya. So from after the tea break, everything is about Meghalaya. Nothing, because every context is different, right? Even in the SDG document, the main document, they say that universal health coverage should be tailored to the different epidemiological, contextual, social, economic needs of every state and country. It cannot be a standardized thing across the world. It has to be contextualized. So how do we do that? That was what we will do after the tea. So let's go for a tea break and then come back here. Yeah. Can we form 4 groups of people to analyze the status and challenges of universal health coverage in Meghalaya? So this is group activity from now until lunchtime, and after lunch, different groups will make presentation of what they have discussed. So you can get the chart paper and pens. So you can please form 4 groups of 7 people each. So whoever you want to work together, as per your preference. And so the task is to discuss the status and challenges of universal health coverage in Meghalaya. And after lunch, every group makes a presentation here for 15-20 minutes. And we can discuss. So seven people group. You can also join the tables if you want. You can shift the tables, because from now on it is all group activity. If you want, you can shift it. Whatever is comfortable for you. The chart papers देते हैं.
Number of people little less.
अच्छा. Whatever, that's fine. So across. It's from the same organization? So
We can just count 1, 2, 3, 4 and all the ones in one day.
1, 2, 3, 4.
We can all assign one number 1 to each, and all the ones are responsible.
Okay, number wise.
They will just call 1, 2, 3, 4, 1, 2, 3, 4, 1, 2, 3, 4, all one together, all two together.
Okay. So one suggestion is that we have more diverse groups. So I think people from the same organization have come together because they know each other. So can we have a mix of organizations?
So what will be 1, 2, 3, 4?
So please. So whatever.
So could you please count 1, 2, 3, 4 from there, and again 1, 2, 3, 4 all one together, all two together. Yes. Then we'll get a more diverse.
Please.
1, 2, 3.
Okay. Yeah, whatever you are comfortable with. I mean, but the idea is to have a diverse group, but whatever you are comfortable with, I don't want to push it. So now you all have to do my capacity building, because I don't know anything about Meghalaya. So please, now you have to do the group activity and make presentations here. So So the question is, how do we use this understanding to analyze the status and challenges of universal health coverage in Meghalaya? So from now until lunchtime, we do this group activity, and after lunch, every group makes a presentation for 15 minutes, and the rest listen and discuss it. Status and challenges of universal health coverage in Meghalaya. Maybe I can write it here. So please analyze the status and challenges of UHC in Meghalaya. So you have 1 hour, please. I think I'll keep my laptop inside then. I can keep it inside, because now they have to present. Based on what we have discussed today, so please focus that whether all populations are covered, whether various health services are covered, promotive, preventive, rehabilitative, whether those things are covered or not, whether it is anchored in primary health care or not, and quality of care. So you please focus on these aspects, population coverage. And let me just mention that a lot of the birth registration is very weak in a lot of places. Without birth registration, you don't know who has to be covered or not. So how do you ensure that everybody is covered in the state? Because health is a state subject. everybody who is registered in Meghalaya needs to be covered. So, whether universal health coverage in Meghalaya is focusing on these issues or not, to ensure that everybody is covered, all health services are covered, and primary health centered focus is there or not.